Good morning from New York and anywhere during the time of the day where you may be around the world for watching the structural heart intervention live case transmission from the cath labs of Mount Sinai Heart, Mount Sinai Medical Center in Manhattan. Just before you begin, a couple of housekeeping announcements. This website, structuralheartinterventions.org, can be used to view the archives, even the same case of today. If you miss some parts, it's going to be archived later today. And obviously, you can also view the previous cases we've done and transmitted in the archives of the website. If during the case you want to ask me a question and I'll then transmit it to the operators or discuss it openly, you can send me an email at info@structuralheartinterventions.org. Let me also say that the Mount Sinai Heart Interventional Cardiology Symposium, cccsymposium.org is a website, will be happening this year, June 14 to 17, here at the Medical Center in Manhattan. And also the next website, Webcast at this particular website is going to be on June 14, same day and time as today, with another structural heart case. Without further delay, let me welcome everybody to today's webcast, which is going to be a TAVR case, a transcatheter aortic valve replacement procedure. I'm George Dangas, the moderator of the case, and let's go immediately to the cardiac cath labs to meet Dr. Sharma, Dr. Kini, Dr. Kovacic, and the rest of the team of this very interesting case.
Get everybody on the picture. All right, George, thank you. Very excited to show another case of our structural heart, which is getting slowly popularity. You know, this thing we started, this is our 10th episode for just less than a 2 year, and about 500 plus registrants we are getting hit to our archived cases. I think the online less, but overall that's the whole purpose. Although it's a little different than about 5,000 plus we get for our complex coronary, but that is 6 years and plus. So knowing that a lot of data were presented in the ACC just few weeks ago on the TAVR, and the TAVR field is really exploding by various the data, with some of them which I'm going to share, really comes this timely. This case which we are going to show you today using the Evolut-R. So with that note, you can see our team members. They are all constant. Same way, Dr. Kini on the left side, Dr. Kovacic on my right side, Asad, our fellow, on the right, and Dr. Stelger, our surgeon. All cases are done with a team approach, and of course, echo and anesthesia. Echo is Partho, although you may not be able to see it. And then we have
Partho Sengupta, that is.
Partho Sengupta, yes. Dr. Partho Sengupta. And then we have our anesthesia team, and so Dr. Levin, yes. With that note, we are ready to show quickly this case history. If we can go to our slides, and then and in the end, next, this is our disclosures next. This is a 83-year-old patient who has progressive dyspnea on exertion, class 3, and has fatigue. Patient actually was referred to me a few months ago because they had echo and had a severe aortic stenosis. But when we did an echo at Sinai, we not only found the severe AS, we also found this patient has a significant hypertrophic obstructive cardiomyopathy with baseline as well as provocable gradient. So clearly it was AS combined with HOCM, and this is the disease entity which is coming up. There have been a few case reports. My fellow Asad presented in ACC a few weeks ago a poster of case 1, and now we actually have about 5 cases where, because of the significant sub-aortic hypertrophy concomitant with the severe aortic stenosis, you worry about the valve. Valve may be dislodged. So we have done the ablation, alcohol septal ablation, and brought the patients back 4 to 6 weeks later. And Partho will talk about that when he's going to show the echo, that you really see the thinning of the septum. That is what the HOCM works with that, and really has done great job. This patient actually felt better, but still has symptoms, good medical therapy, severe aortic stenosis, and had a moderate pulmonary hypertension. Next. Actually, we can go, maybe Partho can show us about the echo findings at present.
Yeah, thank you, Dr. Sharma. Good morning, everyone. Back here, the team, Dr. Levin for the anesthesia. and also we have Amanda Lewis resident, and also we have some engineering backup with Takashi Kayama from Japan for the Hitachi. The system that we are using here, the Hitachi Aloka, is going to be conscious sedation, transesophageal echo with under TE adult probe guidance. So this is something which has been, we are performing most of the cases, conscious sedation are TE right now, and I cannot emphasize the collaboration with the anesthesia team which makes this possible. And we really have learned a lot. This particular case has a complex structural intervention, complex TAVR, and what you see right now are the images of a patient who has already undergone alcohol septal ablation for a significant septal hypertrophy with obstruction in presence of aortic stenosis, which is also severe. And as you will see here, this is the basal septum, which is now thinned out. It's beautifully thinned out. This was bulging up into the mid cavity here. So there was a more than 50% encroachment that was there in this patient at the baseline images before the alcohol ablation was performed. And what you can see here, this has all got flattened. So it has got a landing zone. And you can see here the mitral leaflet is no longer having any SAM-like motion. There is no obstruction. The flow across the LV outflow is laminar. It's all red color. And the turbulence starts right across the aortic valve. And you can see the jet of aortic stenosis that is seen here. When we go into the short axis view, you will see it's a tri-leaflet valve, mild to moderate calcification, some calcification here in the commissure between the left and the right coronary cusps. This is the non-coronary cusp. This is the left and the right coronary cusps. And the valve is restricted in motion with severe aortic stenosis. And also the patient, we have performed further Doppler and color Doppler evaluation to show that there is no intracavitary gradient. Absolutely, there is no evidence of any intracavitary obstruction at all. There is mild mitral regurgitation. LV function is very well preserved, ejection fraction more than 60%, and the RV function is preserved as well. And with these notes, I'm going to give back to Dr. Sharma and Dr. Kenny for the further part of the case.
Okay, we can go back to our slides. Clearly this patient has the CT angio, will talk about it, and risk mortality of 5.85, but because of the COPD and frailty was considered to be a high risk. Next. Next, this is the echo we have already seen. Now, Jason, you take over on the CTA.
Sure, thanks Dr. Sharma. Good morning everyone. So as always, very careful CT measurements to help us set this case up and plan it properly. You can see there around the annulus, it's quite an eccentric annulus or an elliptical annulus with the minimum axis is only about 1.8 centimeters or 18 millimeters. The long axis is about 24.5, giving us a mean of just less than 22, about 21.25 perimeter, 65.6, which is important for an Evolut-R sizing, area 3.4. The fairly vertical and friendly aortic angle for us, an annular angle of 38 degrees. Next slide. Other important measurements, the sinus of Valsalva, quite generous, 31.1. That relates to our likelihood of coronary occlusion, and this is very generous, so not a concern in this case. The STJ height, 19 millimeters, very generous. Ascending aortic width is 29.4, and you can see the coronary heights there. The right coronary is about 15.5, left main is about 14.5. We only get worried if it's below 12, so these are very reasonably high coronaries. We're really not worried about coronary occlusion in this case, given the high coronaries and also the generous sinus of Valsalva width. Next slide. Here's our axis. You can see the actual iliac vessels, the common and the external iliacs, fairly free of calcification, fairly straight. There is significant calcification up into the aorta. However, the diameter of the aorta at that point is accommodating. Next slide. And you can see here, just stepping through, the iliac diameters are around 6 to 7 millimeters, fairly free of calcium and fairly straight. Next slide. So this is just to put it all together. Our patient's measurements are across the bottom. Mean annular diameter of 21.2. Perimeter is almost 70 millimeters, all fitting consistently with the sizing of a 26 millimeter Evolut valve. Next slide. Good. So,
yep. Now, Anu, you want to say anything about the Evolut? How has been the experience now since the Evolut started in terms of recapturability and the lower sheath size?
I think in most of the cases, I would say about 30% of the cases we would go direct. The way the Evolut, the stent valve was actually meant to be, but if any case where we have problems with the groin, then we actually, like we have here, we have a sheath in advance. So if you have to do BAV pre or post, that's the time I think where you have to get another sheath introduced. But as such, for the valve itself is very the release as well as recapture is very good, but I would say it's maybe 5% we have actually had to recapture the valve. Most of the time the release is so good that it just stays in the position that we want to, better than their first generation valve.
Yep. Next slide. This is basically just talk about it. Now, Jason, you want to say anything about your
Sure, if you just
access? Now we can go back to fluoro.
So you just show us the fluoroscopy, please. So just taking you through the axis, this is how we start. This is where we're going to, the large sheath is going to go on the right side, so we start by accessing the contralateral side. You can see a nice clean stick in the common femoral. Next slide. Next, I'll do it. There you can see, so what we've actually done is already dropped a wire up and over the iliac system. You can see there's an 018 V18 wire, which is now entering the body on the left side, goes right down, up and over to the right popliteal artery. We've accessed straight on top of that, again in the right common femoral. We've got our root shots. You can see us setting up the shot. We're aligning all our cuffs and getting our angles for deployment of the valve. It's about 20 LAO, a little bit of caudal as well. And now what we've done is we've put 2 pre-closed sutures in on the right side and set the groin up. We've swapped out for a very stiff wire, and here we're introducing this is an 18 French expandable solopath sheath. We're being very careful, especially here as we get into that calcified area, that we're not getting snagged or caught on anything. And here we are actually expanding that sheath up to 18 French. You can see us being very careful that we're not causing any problems with that calcium. None of that calcium moved or was dislodged, so I was very happy we got that up nice and cleanly. And that brings us up to the case. Dr. Kinney?
So we are ready to cross now. So we're using our AR2.
And it's useful to to point out again that despite patient having pacemaker, we always put a temporary pacemaker to control, personally control easily and reliably the rapid pacing during the procedure.
Yes, the very important point, absolutely.
I can just add, normally with a CoreValve system, we put the pacer from the neck because we anticipate leaving it in for 24 hours or something. In this case, because the patient has a pacemaker, we put the pacemaker from the groin because we know we'll be able to take it out immediately after the case.
Exactly.
Avoiding a neck stick.
You see the valve opening, but you still won't be able to. This is just AR2 with the straight
Wow, that's
Tarumo.
an interesting crossing just at the
yeah.
at the bottom.
Okay, let's show the gradient.
Maybe we can go to a little bit.
Let's show the
projection.
hemodynamics with the gradient.
And we'll try to show one PVC. Let's see how much is the HOCM gradient now.
Maybe you have to give it to the pacemaker.
No, but we should be able to do one PVC.
Yes.
God forbid we can go to a PVC.
Yeah, exactly.
Usually there are like multiple PVCs. Right now we try to create one, we don't get one.
Yeah.
There you go. We got it. We got one.
But still, there is no post PVC.
Not much gradient. Not much gradient at all.
Do you want that wire okay? The other one?
Which one?
It's very sideways in there. You want to go with the soft wire?
So let's
Yeah,
review the
catheter is
position.
okay or no wire?
Let's review the position of the catheter and talk a little bit about how we're going to position the wire into the apex. It's pointing a little bit towards the mitral valve, I would say. So maybe it flips on its own. Maybe go with a soft
We'll
wire.
see. Otherwise, we'll go with the soft wire.
Yeah, that's good.
Get us a pigtail.
I don't know if it's in the true apex though. So that's why. Okay. So go
So
with a
that-
stiff wire.
Do we go with the pigtail? I think.
It's probably mid cavity, but I think we'll probably have to go with
Okay,
a
let's show
pigtail
the
to
echo so
position.
that we
So if you
understand.
see the echo here, so this is a very important step. So this whole wire is curled up submitral just above the papillary muscle. It's entangled here, and the apex is somewhere here. So this is mid cavity, just submitral, and this information can be crucial for biopositioning.
All right, so we'll make
So
a
we're
better
going with a
position.
pigtail and
Yes, I
reposition
think
the wire.
pigtail repositioning will be needed.
But LV cavity is small, right?
Yes, but this wire is currently mid cavity and not at the
Probably
apex.
stay there, no?
It won't stay here, yeah.
You want to go and get the softer wire?
I think your softer wire will be probably better.
Yeah, the pigtail assumes a funny shape there, yeah.
And I'm sure part of that is still maybe residual hypertrophy has to do something about
Yeah,
it.
the eccentricity more so than the, and also it did, I must say, the wire
Yeah.
crossed in a very unusual position. Anu, if
Hit
you
the
recall, it went in
tip
just at
better.
the side next to the other pigtail, so no wonder it's a little bit entangled with the mitral valve.
Actually, while we are trying to position this, maybe I can ask one question to Dr. Stelzer, that how often, knowing that now this whole issue about the septal hypertrophy, subaortic with this AS and particularly with the TAVR is coming more to the light, I'm sure this has been there for a long time. What is your experience that how often you see this incidental finding, or and how often you have to take care of it during surgical valve replacement?
It's a very good question, and I think we ignored it for years and just assumed that it would go away.
Partho.
But in fact,
Yes, now
I had a very low threshold for taking some septum off in patients that, especially if they didn't have a bundle branch block. If they had a bundle branch block and it's a left bundle, that doesn't matter because a surgical myectomy will usually cause a left bundle. However, if they have a right bundle branch block, then I'm a little reluctant to take too much because then you're going to have complete heart block. This patient actually developed complete heart block with the septal ablation, so that's why she has a pacemaker.
Yes.
But I think it will regress. But if you have SAM, if you have a subaortic gradient beforehand, then you're going to have some potential for subvalvular stenosis or at least dynamic obstruction, which can be a real problem, especially if the patient goes into atrial fibrillation postoperatively, and that's a real bad combination. With the stentless valves that we used to use surgically, that was even a worse problem, and that's when I started doing a lot of septal resections to make that not happen.
Great.
So it's a good thing to have this available for the TAVR patients to be able to get rid of it without having to use a blade.
Yeah, I mean, this is the same. We actually have another patient who had an initial gradient of 30-35 millimeter, replaced the valve, did very good. Post-op actually gradient became 70 subaortic. Valve is functioning completely normal, and now the gradient is 100 at about 2 months later. So now question is what to do with this case. Patient has just a mild, they start having some recurrence of his symptoms. So we are
120,
going through
start
that
pacing.
issue.
Well,
Okay,
probably
we are
have to
doing a
pace
20
more.
millimeter with the GMAD. That's good.
Okay. Stop it.
20 millimeter, as we saw, the annulus was average 21, so that's a slightly undersized balloon, very appropriate for the pre-dilatation. And very important because it had a lot of difficulty positioning the wire in all these exchanges, and the wire remains in the apex. And I think we can appreciate in this view where the true apex is and where the wire ideally is versus the original position, which was very much even before the end of the pacemaker wire, truly in the big cavity as Partho had identified.
Okay, we are going up with the valve.
And this is the 26 millimeter Evolut R, and very easy to advance. We navigate, really has made flexible, and I think that probably will translate into, now pigtail has gone into the ventricle, will translate into a lower CVA rate in my opinion. It is already lower, but even further lower.
So very often the pigtail gets entangled, has to be pulled back to the descending aorta, and then advanced again into the coronary cusp. That's a
Very important point.
very usual
That
and
you have to bring it
expected.
down to the descending aorta and then go back up. Absolutely.
Very expected point. And as you see, spend a little careful time because we really need it to be
Okay.
in the lowest,
Going
most
to go
cusp.
cine.
Yeah.
Inject. Okay, start releasing.
Okay.
So again, this valve is going to start pretty much where this
Diving a
radiopaque
little.
portion
Yeah,
is,
coming up.
Yeah,
and
good.
not in the very
Cine
end.
again.
Okay.
Cine.
You want to jiggle a little bit the valve?
No, nothing. That's the old
Good.
valve. So far,
This
so
should
good.
open up
Yeah,
pretty good here.
Yeah.
Pretty
Watch
high.
that
Okay, start
top.
pacing.
It's going to flare
120.
nicely.
Okay, it's anchored good. Cine.
You're not quite anchored on the top there yet.
We're
good.
borderline at the top,
Yeah.
but hopefully it
Borderline at
will
the
be
top.
fine.
Okay,
Go
stop
ahead,
pacing.
Let me let it jiggle a little.
Yeah.
Okay. I think we're engaged.
Okay, final picture.
All right, the valve is fully functional now, so we'll have time to do some evaluation.
Okay.
And
We're going to release now.
looks like we're in a depth of about 2.
Yeah.
Fully
And, As
released.
soon as
Yeah.
we release it, the valve will kind of tilt a little bit in
Both
the
paddles.
Come on, it's
real
really in the
position. Let's see where we are now. It always tilts slightly and aligns a little bit better when we pull it out.
I think we came up a little bit.
Up in the-
Look.
So, and then we, have to marry the nose cone with the sheath in the descending aorta, so it's somewhat straight, and then we take it out before checking the pigtail. Partho, how does it look from your point of view in the echo? Can we
Yes,
show us a longitudinal?
It's
But look at the echo probe. Conscious sedation TE. I think that's a very unique. The mastery of Partho and the newer machines.
Thank you, Dr. Sharma. So what we have here right now is the under expansion of the valve. With that 12 o'clock position, you can see that there is a
22.
paravalvular leak, which is a
main
little
is
bit
22.
over
the-
mild, and,
Yeah,
and
we
the under
see 'em.
expansion you can see also there's a gap there, and there is a transvalvular regurgitation, which is catheter related. We don't have to
Well, it
worry
doesn't
about
matter.
that,
True, true.
but it looks like we'll have to expand it.
You want to do a aogram or no?
No.
Yeah, let's do an
want
aogram
to?
to
Okay.
see how it goes.
Creatinine is okay.
Yeah.
Yeah, let's do aogram for teaching
Inject.
purposes. Bring the angiogram big picture, please. I don't know, I think it's really tiny.
But while we're just zero.
Just sitting there, zero.
But if you-
Moved
I-
up
I-
on the
I-
other
Got
side.
that.
I would be a little careful here. Allow it to remodel a little bit,
There's not
maybe
much
put the
AI.
pigtail in the LV to measure the LV pressure, and
Boy,
we
it's
may be
crept up,
okay
hasn't
here.
it?
On this side was
Yeah,
so low.
yeah, it was lower there, but it's crept up.
Yeah.
Yeah, because of the pivot that it did in the end.
But now how much gap we are talking, Partho?
It's
Yeah,
truly,
so-
it's truly small here.
Yes, so I think there is an under expansion. You can see here there's a gap, which is
But we don't see much AI.
Yeah, I think you're at zero.
Diastolic is the
You're at
same.
0 level on the right side, and at 1 or 2 on the left. And let's just do the LV hemodynamics to understand what's happening.
So look at this long axis view. You can see that there is that under expansion of the stent leaflet, and you have about 2 or 3 millimeter. I mean, it's very close to the annulus. It's almost a 0 to 2 to 3 millimeter implant, but it looks very stable and with a gap there. But the interventional team has to make a decision whether they want to leave this or.
Wow, there's
or-
a lot
or
of color
expand.
over there, Partho.
I think except the diastolic.
Very nice
is
picture
40.
we see.
We started,
So
they
that
said
there is
52.
there is also a little bit of
So let's
MR.
look at hemodynamics, please. Let's look at the.
We need some blood. Diastolic is going way down.
Can we re-zero again? Let's quickly
let's
re-zero.
re-zero and flush the channels. That's
Yeah.
good. Everything is low.
Diastolic pressure.
Everything seems
Right?
to be low.
Let them
Oh,
re-zero.
you have a
quickly.
different one.
Re-zero the
We started at
systems.
52. You're okay. Right?
Below.
I think there is AI, Dr. Sharma.
Okay, we're going up.
Yes.
Right.
Let's
I think we should
elevate a
begin
little
to,
the blood
See,
pressure.
blood pressure is low.
Let's elevate a little blood pressure before we do another inflation, I would suggest.
No, but because the diastolic pressure is low
No.
and we have some.
We started in the 50s. We are below 40 now.
No, but now question is
Systolic's
you
only 80.
definitely do risk of moving the valve up.
It won't move.
It'll be fine, Dr.
Yeah,
Sharma. It looks
it's a
pretty
good
well
for
anchored
planting.
as long as the pressure is low. Yes, I think we might have to
It
take
won't
that.
Okay,
risk
one
a little.
second. The pressure is going up and the diastolic is going up also. One second. Let's recover the pressure a little bit.
And I think that's a very important point also. I think overall, looking at the patient natural history, We think that it's extreme risk. We are not talking about a long-term outcome. So maybe 1 or 2 years, maybe we have low very high threshold. But somebody who has a reasonable chance, like this patient, of could be
180.
good 5-8 years. So in that particular case, you will like to go, and this is where the decision was made that we should go and try to expand this valve a little further. Right? Everybody agrees?
Agree.
Particularly Dr. Stelja?
Yeah,
right?
I think so.
Good.
Okay, we're going pacing at 180.
1 second, what size balloon are we going to use? And let's look at
22.
it. We don't have a visual yet. here.
Okay, go to the
22
fluoro
true.
now. It's a 22 millimeter true balloon.
Okay, start pacing 180.
Pacing 180.
Now once you start pacing, make
gotta
sure your
go a
blood
little
pressure
bit
way
lower,
below
huh?
40. Yeah,
Okay.
go up.
Yeah, but that's
Go.
Nice.
Go. Good. No, didn't expand full. Okay,
That's it.
stop pacing.
Off
You
pacing.
don't need much.
Right, expand it.
Much better. Good expansion. And then you just see a trivial paravalve.
Okay, let's do the aortogram now.
Okay, let's see see the diastolic.
Diastolic came up.
Show us the pressures, please.
Show both hemodynamics and the valve, the fluoro. Good. Yeah, remember diastolic went down to less than 40, now it's coming up to 50. Want to just do the aortogram? Go to LVEF.
Want to take out the wire.
Yeah. And if it looks good, we can take out the wire.
Yeah, it definitely expanded better, particularly on the in the non-coronary side that we see here angiographically, and also obviously a little bit in the left side.
Okay. Inject.
No AI.
Has he moved a little bit or we are okay?
We are okay.
I think
Doctor.
it just looks a little different in different
Because
angles.
this is a different angle.
Yeah. Good, because there is no gradient. There is no AI now. Good. So I think with that note, we finished from the valve point of view.
Diastolic actually is 60 now.
Yeah, diastolic has gone up to 60 plus. This is what our goal was, that to decrease the regurgitation which we have. The valve position is 0. We always say that don't let the patient sneeze.
Yeah.
It may go up a little bit.
We have
to
to give
anti-sneezing.
anti-sneezing at discharge.
Just put the chart.
Yes, definitely there is a 0 on the left side. and,
Didn't move, right? It stayed
yeah.
the same place.
Yeah. But echo wise, it's a
0.
Yeah,
good
it's good.
position right there. And while Dr. Kovacic is going to take care of the groin issues, we can go back to our presentation, which we do just basically talk about the latest topic in the field. We can get to our, clearly the core valve. Now actually advantage is more and more being done femoral because you need only 5 millimeter of the vessel diameter. Next. And basically next is that because of the data of the partner 2A of the TAVR versus SAVR in the intermediate risk, next, which was basically, we have 2 trials next, which is 3 to 4 to 8 to 10, partner 2A completed and reported, and the CERT-AVI using the CoreValve / Evolut is still ongoing. Next. Next. So I think these are multiple slides set, keep going. So basically the patients were randomized, which are STS of 4 to 8, either transfemoral route or transaortic route, and that's a very important, because what happened is transaortic, they use a SAPIEN 3, and in the transfemoral were both SAPIEN XT and SAPIEN 3 was used. Because outcomes were different in the transfemoral versus transaortic, because 25% of patients were non-transfemoral in the same partner 2A trial. Next. And the primary endpoint was 2 years all-cause mortality or disabling stroke at 2 years. Next. And clearly we were all waiting next to have the data to be presented. Very excellent follow-up was presented by Dr. Craig Smith with the simultaneous publication next in the NEJM. And this is basically, usual happens with a trial of this magnitude, some non-compliance, non-follow-up next. And basically during the trial, the valve changed from SAPIEN to SAPIEN XT to SAPIEN 3, and the various sizes were available. Next. And basically overall, the group was fully matched in the baseline characteristics with STS risk score of about 5.8. And remember, it was 4-8, so about 6 was the right the randomization that patients were appropriate, patients were put into the trial. Next. And these are the various individual procedural endpoints. Basically, as you can see here, that overall length of stay was 6 days with the TAVR and 9 days with surgery. And of course, the procedure time clearly a little higher with the surgical, significantly higher with the surgery. Next. These were the acute complications with the procedural death around 1% in both the groups. And 2 valves were used in 2.6% of cases with a 1% embolization, annular rupture 0.3%, coronary obstruction about equal in both the groups, and of course a little bit of infection which happens in these cases. Next. Again, within normal limit. And this is where the money is. The most important data which we were waiting eagerly of the comparing the surgery versus TAVR in this intermediate risk group with the 2-year all-cause mortality or disabling stroke. Next. And you can see here that this is the curve for the surgery. Next. At the 30 days, 1 year and 2 years, and clearly the TAVR comes non-statistically numerically lower than surgery. Next. And then that was the ITT, intensity to treat, and actually treated, you see a slightly more gap. So p-value instead of 0.24 become 0.18. So you have about 2% advantage of lower death and stroke with the TAVR compared to surgery. Next. And more important is the femoral group, which was the 76% of the patient population. There was almost 4% decrease in the mortality or disabling stroke with a p-value of 0.05. So once you have a transfemoral, you have a superior advantage of the valve, our sapien valve compared to the surgical valve. Next. And these are the individual points, 30 days and 1 year, basically just to show once again that stroke was no longer. Remember, earlier trials of the partner had a stroke almost twice the surgery. But clearly in the newer generation, the sapien valves with a sapien XT and sapien 3, there is no longer higher stroke. Disabling stroke, again, numerically lower. And what we expect, there is also happen is little trade-off. What used to be the pacemaker rate of 4% or 6% has become to 8-10% now because of the sapien 3, which has this additional cuff, which stays at the outflow tract, so that clearly the pacemaker need has gone up. Next. And also higher life-threatening bleed and AFib in the surgical group versus TAVR, which is expected. Next. Now this is the 1 year data. As you can see here, all stroke again, identical, disabling stroke identical, slightly TIA numerically higher in the TAVR group, but overall the TAVR performed excellent compared to surgery at 2 years in this intermediate risk group overall. Next. Now then, basically the NYHA class, as you can see that from the left side, which is the orange and the yellow, became at 30 days and 2 year more green and white, which is class 1 and class 2, and was identical between 2 trials. Next. And the important is, which has been shown now by multiple studies, that you get a better effective aortic valve area, orifice, with the TAVR comparatively compared to surgery. And maybe I'll ask Dr. Stelzer to comment on it, because this is now the consistent finding. And question comes, will that be important, particularly more for young person? On a long run, probably won't, because here the mean age still was 81 plus. But right. Question is this difference of 0.2, 0.3, which is coming up in various trials, that TAVR having a better effective aortic orifice compared to surgery. How much important that is, Paul?
Well, I think it's an important consideration. I think we are being made aware of the need for a more hemodynamically efficient valve implantation, especially in younger patients where they pay a price for that in terms of long-term survival. And if we're going to put a surgical valve in a young patient first, it's even more important to get in the biggest possible valve we can, even if we have to enlarge the annulus, in order to make it both more efficient in the first place and more amenable to valve-in-valve TAVR in the future. Because if we put a small valve in the first place, we're not going to be able to make it bigger with a valve-in-valve procedure. And I think that statistically, when you look at the STS database, 55% of all the valves put in America are either 19 or 21 millimeter valves. And that's terrible. Really, it's really terrible when you think about the hemodynamics of those valves and when you think about trying to rescue them in the future. So we're not doing anybody a favor putting in that size valve whatever age they are. You can get away with it in the 90-year-old and the 80-year-old, which now will obviously have much more a tendency to put in a TAVR in the first place. So yeah, we'll help them. But I think the answer isn't to just put TAVRs in 40-year-olds. The answer is to put better valves in the younger patients in the first place, surgically, so we can rescue them later.
That's a very important. Actually, Dr. Stelzer has done 2 of my cases in last 1 year where they has to enlarge the root because the original surgical valve was too small. And since it was too small, we could not have gone for surgical, another TAVR or TAVR in that particular case. Okay, let's keep going.
This is a very important point to understand that the limitations of the practice of surgery around the United States and see how we can make things work out about this very important point, the size of the valve placed. That maybe perhaps obviously actually was not under any attention the previous years. Go ahead, Dr. Sharma.
Good. Keep going next. Then, of course, from the paravalvular regurgitation, as expected, that with the TAVR you leave some more than moderate regurgitation, which is part of it next. But more important, what we learned in the earlier SAPIEN trial, that even mild, trivial, moderate, severe, there was a gradient in terms of mortality. But then when we had the CoreValve trial, only gradient happened when there was severe. Same thing happened with the now SAPIEN, because once you have severe AI, and mortality means your valve was not good. So your technical issue. So same thing happened here, that only gradient is with a severe aortic insufficiency or paravalvular leak. So that's a very reassuring. So clearly, we need to do everything to come out of the lab with a minimal or mild aortic regurgitation, and various techniques which we have highlighted, whether balloon dilatation, valve in valve, and so need to be done. Next, or pulling sometimes the valve. And this clearly put into the nice conclusion. But in the intermediate risk patients, TAVR was similar to surgical aortic valve replacement with respect to the primary endpoint of death or disabling stroke. Next. Now, at the same time, there is another paper was published, and of course, data were presented in the ACC. That is the SAPIEN 3, and SAPIEN 3 was used in the partner 2A, and they have their own observational study of SAPIEN 3 in the intermediate risk group. Next, and what they did next, that they did a propensity match analysis next, that basically in the SAPIEN 3 group of 1,000 patients on the left side, that the data they compared with the surgical AVR of the partner. Clearly, it's not a directly head-to-head, but these were 1,000 plus cases were compared against the surgical data of the surgical AVR of the partner 2A. Next, and basically endpoint was 1 year of all cause stroke, mortality, and moderate to severe AR. Next, and basically found that event rate, as you can see, became half with the SAPIEN 3 compared to surgery at 1 year. This is a totally little different group of patients, and so, but overall, again, emphasizing that the valve, the SAPIEN valve does very good. Next, in the intermediate risk, these are the individual points: the death, stroke at 1 year, disabling stroke. So all are in favor of the SAPIEN 3 TAVR. Again, this is not a direct randomized comparison, observational of the partner 2, but similar time period against the SAPIEN 3. But you see now what happened. Pacemaker rate has gone up. And this is the trade-off which has happened, that you decrease the paravalvular regurgitation with additional cuff, which sits at the outflow tract, and that really cause the less regurgitation, but clearly irritate various bundle branches and cause the need for pacemaker. Next. So this becomes really important. These are the various other endpoints at 1 year in the SAPIEN 3 trial. Next. So clearly it was implication of the evidence that TAVR should be considered as the preferred alternative to surgery in intermediate risk patients with future should consider expanding the indication for TAVR. Next. And this exactly we are, the SARTRAVI trial just getting to the enrollment next, which is basically the plan is as soon as the FDA gives the green light for the intermediate risk approval, that the trial will close enrollment hopefully by end of this month, and then all patients then will become in the continuous access TAVR group, getting the CoreValve, and so. That is what we use at our center quite significantly, 80+% of cases. Next. And therefore it puts it together now that in a high risk, extreme risk TAVR, now you can make it in the intermediate risk TAVR also, even while we are waiting for the SARTRAVI trial data, and of course in the low risk. And next, and this is a very important point, that now we actually FDA has approved two trials, one Sapien 3 with a low risk and the Evolut-R. All these patients are the STS risk of less than 3, but age more than 65. Just because of the valve issue or durability, not knowing,
Right.
the minimum cutoff is the 65. Now, Paul, you agree with that, the 65 years of age?
Well, I'm glad it isn't any lower because, as you say, the long-term durability is extremely limited. And there is this paper that was just published in February about, I think it was about 1,500 patients registry looking at this new disease called VHD, valve hemodynamic degeneration. Yep. And the patients at greatest risk were the patients who had a small valve originally implanted, yep, and who were valve-in-valve. And there's, again, a big warning. Okay, surgeons, don't put in a small valve or you're going to have both of those risk factors for premature degeneration. And by that, they meant more than a 10 millimeter mean gradient within the follow-up time, which was only a mean of 20 months, where the average on the people who didn't have those risk factors was 0.3 millimeters of mercury mean gradient increase per year. 0.3, wow, which is wonderful for the TAVRs. Yep. But if you're in that bad risk of small valve initially implanted or valve-in-valve, and I fear a lot of those were in small originally implanted valves. So we really have to do a better job of putting bigger valves in the first place, or we're really going to be putting a lot of people on that bad curve for outcomes.
Absolutely. Great point. Now, I know, knowing that you have done both the Sapien 3 and Evolut, what is your take home based on these data now? That looks so good for Sapien at present, although we don't have the Evolut-R data for long term, but they're very impressive data.
We most of the time, I think we have shown Evolut, have you seen, is implantation. It's just, I think, a learning curve for every technique, but once I think you're there, we don't know what number we have to give to number of cases that they have to do. Both valves, I think, would be easy, but there are a couple of differences that I would say as an interventionalist, what we see that, the post-dilation, though the recommendation is once you have done this, self-expanding stent valve like Evolut, that you have to give 10 minutes to 15 minutes wait and see for it to expand to see if there is any residual AI, but most of us interventionalists or surgeons are not going to wait that long to see if there is change in AI. We will go with the hemodynamics or by the echocardiographic findings where they say it's not expanded, we go and post-dilate. So the post-dilation is almost, in our center, is close to 40% or so. But going back to Sapien, since it is a balloon expandable stent, post-dilation is less than 5%. And we never see any AI like you would see in the Evolut. But what I think more important to me as an interventionalist is, since we are doing this now in a intermediate risk or in a younger patient, even 70, 80-year-old, in the last 2 years or so, we have had handful of patients who are coming back to us with the MI, and we have to recath this patient. So doing a coronary angiogram through the stented Medtronic CoreValve or the Evolut is very hard. I would say you need another year of interventional fellowship to understand how to engage the coronaries through this stent graft. Often we need special techniques as guideliner and all that, just to engage and get coronary angiography. And if you have to do PCI, it's technically very challenging compared to the Sapien. Since the valve is nicely placed just like the surgical valve, engaging the coronary arteries is much easier. So I think this is a very important point we need to take into consideration as an interventionalist, because when we are doing this in intermediate risk and younger patient, right, we will know that years further down that they will come back to us with a coronary artery disease.
And that's an important point. Actually, we have done now maybe about 3 dozen cases of PCI post-TAVR, and major, if we have to go through it, we can. Actually, I just had a case about few weeks ago, was done in the good center here. They didn't want to go through the the core valve and open the left main, and we did. But just this question will come very, very often in the future once we start getting this valve to the younger patient. With the same token, In the past, we used to give coronary artery disease less importance and the TAVR more. Now, in those cases where we think significant CAD, we fix the CAD first, wait for 1 or 2 months, and then you do your TAVR. Let's go to complete now our presentation. If we can go back to our slide next. Younger patient, we all know you can get it if they are a prohibitive surgical risk. Next. Just to, and this actually goes to our guidelines of December 2014, which rapidly has to change. That is the first statement. The surgical AVR is recommended in patients who meet indication for AVR with low or intermediate surgical risk. Next, in my opinion, that clearly that partner 2A data and knowing the CERTAVI data, CERTAVI ongoing trial has shown that intermediate risk, the TAVR is doing quite well. Next, and this basically show, in my opinion, should rapidly become preferential TAVR, maybe a class 1 indication. Next, quickly, that our randomized clinical trial and observational study using SAPIEN valve has shown to be equivalent to surgery in intermediate STS risk patients with survival advantage of TAVR in the transfemoral approach and perhaps in use of SAPIEN 3 valve. Hence, TAVR should soon become the class 1 indication by ACCHA guideline in intermediate risk AS patient. The issue of increasing pacemaker need after TAVR with SAPIEN 3 valves or maybe with the CoreValve, which we'll know, that needs to be addressed when TAVR being implanted in younger patients with a low intermediate risk. And a special TAVR technique which has been done in the literature is that you do a zero implantation like this case. It didn't matter in this case because we already have pacemaker, but you do a 0 or 1 millimeter implantation even with the SAPIEN 3, then your pacemaker rate may go down to less than 2% compared to 12 or 13%, which is there now with the SAPIEN 3. Next. So basically, we go to 3 quick questions. The partner 2A trial included AS patients with following STS risk, less than 4, 4 to 8, 9 to 15, and more than 15. Next question. The following statements are true about the results of the partner 2A trial, except that mortality was higher with a surgical valve versus a transfemoral TAVR at 2 years. Mortality and CV at 2 years was equivalent in surgical valve. Lower pacemaker need for TAVR versus surgery, and TAVR valve had higher aortic orifice area compared to surgery. Next. Lastly, the SAPIEN 3 observational study of intermediate risk AS comparing surgical valve to partner 2A, patients showed the following. TAVR having the lower mortality at 1 year, TAVR having lower mortality and CV at 1 year, TAVR having equal rehospitalization, TAVR having higher permanent pacemaker use, and all of the above. Next, so we can go with the quick question next, which is basically we know the partner 2A was 4 to 8% STS risk. Next, the answer to the second basically is the C, the lower permanent pacemaker need. That's not true. Pacemaker need was exactly identical with the TAVR and SAVR, rather numerically higher. Next, and the last question is that where was the advantage and all of the above which have been shown with the benefit of the SAPIEN 3 in that observational surgical registry. So with that note, Dr. Jason Kovacic has already completed the groin closure. Maybe just quickly, in 1 minute, you can show where we are now.
Sure. If you just
before
show the fluoro images again, I'll just take you through. So this is a great teaching point actually for how we do the closure. So I'll just skip through these images. So as you know, we had the large sheath up. We also had a wire up and over. So what I've done in this first shot, we retracted the 18 French sheath down into the right distal common iliac. We've got now a crossover sheath set up on the left side. We're doing DSA just to the aortoiliac bifurcation to check that there's no extravasation, no rupture, no problems. And you can see looking good so far. We now take that crossover sheath up and over the aortoiliac bifurcation. The crossover sheath is now across to the right side. We've retracted the 18 French sheath further, taking another shot. Now, the patient's creatinine is normal in this case, so we do have the luxury of being able to take a lot of these extra shots. At this point, we've actually pulled out the 18 French sheath. I've deployed the per-closed sutures, and you can see there's quite a pinch there of the common femoral vessel where we actually had the main sheath enter the vessel. We've deployed the sutures. At the moment, I've still got both an antegrade and a retrograde wire going down, so we've got great control of the situation. So what we do in this point is actually we don't fully cinch down the per-closed sutures. We pull out the retrograde wire and deploy and inflate a balloon. Inflate a balloon, which you'll see here. They haven't saved these images properly. My apologies.
Yeah,
we went through.
Wait one second.
Show the final picture.
Yeah. here.
Oh, this
We're
is the
actually
balloon. Yeah,
ballooning
you can
here,
barely see it, but we can
ballooning
see
here.
the
We're
position
taking
of the
more
balloon.
shots here.
Yep.
And you can see, looking better, but there's still a little flap or something going on there. We weren't happy, so we did some more ballooning, which was here. Checking again carefully, looking much better.
Yeah, there is a little bit of a disruption there,
Little
which is
disruption,
not
so we
unusual,
did some
but,
further, yeah, I agree. We did some further ballooning,
you know,
Beautiful.
looking much better.
but this looks good, the flow, and it's going to heal
Very
fine.
And this
Little
is, I think this is our final shot here. Final shot there. So it shows you the value of
Do the
having
final.
that wire
That's okay.
down,
Looks
doing a
nice.
little ballooning, bit careful, and the vessel looks beautiful at the end.
Okay, so we are done from our live webcast of the relay of this very interesting case, right from the beginning to end, including the vascular access and vascular closure.
Yeah, this
Partho
was-
has to say something. Partho.
As a closing comment, if you can just show the images. This is a conscious sedation, so as the technology evolves, we will be able to do everything, 3D echo, all the parametric imaging.
Wow,
and
we
this
see
is
the vortex.
this is a advanced technology called as vector flow imaging. This patient, as you can see here, this is the your valve, and this is the flow which is coming from the atrium, and it rotates perfectly, goes out and exits out without any turbulence. So this is a complete normalization of the blood flow into the ventricle and as it's exiting out.
That's
This is
amazing
two-dimensional
imaging.
blood flow. So it will be a good synergy to have all these advances in technology and do all this process in conscious sedation. There's no reason TE cannot be done in conscious sedation in this complex procedures. Thank you very much.
All right.
Thank
This
you,
is-
everybody.
This is great. This was a great review and a great discussion about the valve sizes in aortic surgery, and close with a very impressive imaging by the next way to image these valves by Parthos and Gupta. This was great. Congratulations to the entire team. Dr. Sharma, Dr. Kini, Dr. Kovacic, Dr. Stelzer, Dr. Asad Khan, and Dr. Parthos and Gupta, as well as the anesthesiologist, Dr. Levin, which we cannot see behind the equipment. Let's say goodbye to the cath lab, but let's stay together to review a couple of the dates coming up for us. On the June 14, we'll have another live webcast of a structural case at this website at structuralheartlivecases.org. At the same time, anywhere you may be around the world, or around 9 a.m. Eastern Standard Time here in the United States. And let's invite everybody to register. Registration is open already in the website cccsymposium.org, and join us here at the Mount Sinai Heart Interventional Symposium of this year on June 14 to 17, 2016 here on the premises, and get the chance to view the live cases and interact with the faculty in person. Goodbye from me, and thank you for joining Mount Sinai Heart once again for a live case. Use the archives if you want to view this case later in the week or another case we've done earlier. Goodbye from New York.